program, and then having a budget for that program. And yes, some hospitals do have fragments of it, but it's not comprehensive enough and consistent enough to have a history that's we're showing, the report shows that we couldn't do enough data. We have some, one or two that are doing a great job, but that's really implemented.
Some of them commit to purchasing the equipment, and part of the equipment that goes with it to make it successful are slings. So you purchase this pre-mill ceiling lift equipment, but you don't have the slings. You don't purchase them, or they're on the other side of the hospital. So it's very haphazard. And it seems, I'm sorry.
You really work with all the pieces together.
Exactly.
Policy, the equipment, the training.
I'm just curious, has this ever been subject to a collective bargaining agreement? Have you ever?
We do have some contracts that address it, but not to the detail of this. So to endeavor to create a committee, endeavor to do the equipment, but it's not the whole package. And it's just sinful that the things that have happened to me happen to so many others and it can be so easily reported.
Thank you all very much for your testimony, and we are very sympathetic to them.
Thank you for your questions.
Many nurses who have been injured on the job. Pretty shocking, the level of work-life injuries on nurses.
Can I remember to the patient that is here from the also need to move and all of other things?
We want to welcome Representative Bolger. Okay, Representative did you?
Good afternoon, everyone. Thank you for taking me out of turn. Appreciate the courtesy. Going to be kind of brief, because I would look forward to talking to you both again further on this. I'm here on 1904 and 1905, filed by myself. The first is to require hospitals to have an annual meeting for the public, and the second is to require hospitals to have governing body training. As you may recall, 19 months ago, the hospital in the Northern Berkshire region, North Adams Regional Hospital, suddenly went out with a 3-day notice to its employees. And it was quite a shock. The hospitals had been open since 1885, open for 129 years. And we all know that hospitals are strained these days by financing. So certainly, I think something could have been done somewhere along the line to keep this one going. It really was devastating to the region. It wasn't just the hospital, but also the JVC Nurses Association went out of business, affiliated with the hospital. The hospice group is no longer there, and along with 3 medical groups that were also owned by the hospital. Family medicine, OB/GYN, and the general surgery practice. So we all went out, leaving about 530 people out of work in a 3-day notice. It was really kind of amazing. I remember the current administrator saying he wished he could have done something else, but clearly something else wasn't done, and we lost a huge not only healthcare facilities in our region, but also at least the second highest employer in the whole region. So I went to many community meetings. They still go on every Tuesday right now. And from what I was hearing at those community meetings, I went searching, looking for reasonable common sense legislation that might help, not this situation is over the dam, but perhaps other situations that might come about. So the first 1904 is to require hospitals to conduct an annual public meeting. It's very simple. It's language that I found that other states have. It requires the hospital to meet annually. It outlines very plainly the ways that they are to notify the public, and it also states that the chief executive officer of the hospital and the chairman of the board of the trustees, so at least 25% of its members, be present at the meeting to hear, not only give a presentation on the status of their hospital institution, but also to allow members of the public to ask questions as to their hospital. Yeah, I think it's pretty common sense that institutions be able to meet with the public, that they are in charge of very serious matters that are out there. The 1905 was an act requiring hospital governing body training. Again, I go back to my community meetings and people would say, how did they let it happen? Got a full board of trustees, a doctor, an counselor, other people on the board. How could they possibly ever let that happen? Well, this is legislation that I found that, again, other states have that require some training for all members of the trustees of a hospital board to have. Again, plainly written, talks about ethical responsibilities, the role of the governing body, and what they're supposed to do as members of a healthcare organization and their legal and regulatory compliance issues. It does require some hours of training, and it sets apart a regulation for people who are already board members, not just new members, to have same such training. Again, it's, I think they're common sense type of things that are out there. There's things that Massachusetts doesn't currently have, but are out there around our wonderful country. And I think that due to the horrific situation that we had in our community hospital, that some attention should be made to this. And I look forward to serious consideration of these bills, and would be happy to meet with the chairs at any time that you would like.
Thank you very much, Representative. We appreciate the action you're taking here on behalf of your constituents in your district. It was a very, very unfortunate situation, as you said.
Thank you.
Representative Kennedy, did you want to testify? Please.
Thank you, Mr. Chairman, Madam Chair. I am here to testify on House Bill 2074, an act relative to patients' rights. It's very straightforward. There's also a refile. What it would simply enable is patients upon discharge from the hospital be able to take their unused medications home and eliminate the need for, obviously, refills and, of course, eliminate waste. And if I may, also, I'd like to weigh in on House Bill 1918. It's done in conjunction with the American Heart Association, and my inspiration for this bill is, of course, I'd like to say Representative Cusack, but it's not Representative Cusack. It's my constituent friend Christina Hill in the back, who is a stroke survivor. And I just simply respectfully request a favorable. And thank you so much.
Thank you. We appreciate it. Okay. Next, we're going to hear from, we're going to go back to House Bill 1914, Senate Bill 1124, Christina South.
Senator Lewis, Representative Hogan, and other members of the Joint Committee on Public Health. My name is Christina Sauer, and I'm a registered nurse and also a member of the American Nurses Association of Massachusetts. We represent nurses throughout Massachusetts, and we strongly support this bill and act relative to safe patient handling in certain facilities. As an RN, I work at a city hospital, and my patient population historically consisted of stroke patients, and just recently we switched over to a larger population of geriatrics. The physical needs of these patients takes its toll on nurses and support staff on our unit. So I started as a nurse 7 years ago, and much of the training surrounding patient handling was a learn-as-you-go method. As a new nurse, I did not know the shortcomings of this approach. I was required to manually lift, move, and reposition patients regularly. Approximately 5 months into my job, my back started hurting. There wasn't one thing that I could say that set it off, but it just increasingly started to hurt, and I started having muscle spasms, and they were shooting down my leg. Probably didn't want to admit that there was something going on, went for an MRI, and I ruptured discs. So I had to take time off from work. There were medical costs. I am back at work, but now I have to endure the long-term consequences of having a chronic condition. What concerns me most in the scenario, it's not uncommon, and it's just not nurses. It's certified nursing assistants, all sorts of healthcare workers, who are responsible for helping patients with their basic activities of daily living. The Bureau of Labor Statistics reported in 2014 that work-related musculoskeletal disorders accounted for 39% of the total injuries and illnesses reported in the healthcare and social assistance industry. They also reported that nursing assistants incurred one of the highest rates of musculoskeletal disorders in 2014, and there were 5 times greater incident rates than other professions. A review of historical data shows no real improvement in this area. Without a change in our laws, healthcare workers and patients will continue to run a higher risk of injury and patient handling. The Center for Disease Control and Prevention reports that the single greatest risk factor for overexertion injuries in healthcare workers is the manual lifting, moving, and repositioning of patients, residents, or clients. However, with vast improvements in technology over the years, we still continue to promote the manual process. And I can speak to that because I'm on the floor and we still do a lot of things manually. We just started to use the Hoyer lift. Most people are afraid to use it because we're not properly trained on it. Nurses and other healthcare staff who have a vested interest should be allowed to be part of the process in selecting the equipment. And there should be a mandatory annual training on the equipment and also on just ergonomics. What are the proper ways to kind of move patients around? You want to keep the healthcare workers safe, but you also want to keep the patients safe because they're at risk too for injuries. Our laws should support all healthcare employees work under safe conditions. I thank you for your time and
Thank you very much for your testimony. Jeffrey Key? Yep. Key?
My name is Jeff Keane. I'm a registered nurse, member of the Association of Registered Nurses, and I've been an operating room nurse for 10 years. I come to speak in support of this bill. As an operating room nurse, our patients are primarily asleep when we take care of them. So all of the burden is on the surgical team, the doctors, nurses, and technicians in the operating room to move these patients into the proper position and make sure that they're positioned correctly and there's no pressure points. So while they may start out laying on their back, and then we have to move them to on this side. And we don't have any equipment to help us with that. Just brute force, lifting, moving up, moving down, left, right. And it puts a lot of strain on the back and possibly the neck. So it's a real concern for us. I just come to support this bill and encourage you to support it. Thank you. Thank you.
Thank you for your testimony today. We appreciate it. All right. That was the last person signed up to testify on those 2 bills. Was there anyone else who wanted to testify on House 1914 or Senate 1124? Anyone here to testify on House Bill 1915? Cronin? House Bill 1916 by Massacusetts. House Bill 1917. Okay, then we're going to move on to House Bill 1919 and Senate Bill 1189. And I believe we do have somebody signed up, Allison Perrin from the panel.
Thank you.
Okay, welcome. Welcome back.
Thank you. That's what I ended. bookends my lead with this. Thank you so much, Chairwoman Hogan and Chairman Lewis and committee members. We are here on an act relative to prevent death and disability from stroke. This bill will actually set up a stroke system of care to help us reduce the instances of death and mortality and disability from stroke. And really what we're asking for is for the state to put in place the ability to recognize the best medical centers to treat stroke so that we're ensuring the best care is given to stroke patients. The hospitals can seek designation to be acute-ready, primary stroke service, or comprehensive. The current system that we have in place is pretty much an acute level place. There's many hospitals that are actually working at a much higher level as a primary stroke center or even comprehensive, and they can certainly, when this system comes in place, seek that designation. What we really are hoping for is that that people that are getting to the hospital treated quickly, you can reverse a majority of disabilities from stroke with a very simple drug called TPA, which is a clot-busting drug. And so, if we get people, to recognize they're having a stroke, get to the hospital and are treated quickly, we can see a really reverse of stroke, which will end up really costing the state a lot less money and giving people back a higher quality of life, which is really important to us. We also want to make sure that the Department of Public Health plays a role in the system of care and make sure that they're collecting data and measures to know that people are getting treated properly for stroke, as well as EMS setting up protocols so that they know when someone is diagnosed in the field as having a stroke and calling that they're going to the best possible hospital. A lot of people think that they have to go into Boston and go to some of these larger centers, but depending on your stroke, you can be treated within your local community hospital. So we also want to make sure that people are going to the right hospital if it's their closest or if it's not, and that when they're coming back for kind of the continuum of care, they are staying within their community hospital as well. For us, we know that if they're treated quickly, like I said, they can really provide and come home with the best quality of care. And we have 2 stroke survivors that can give you a little bit of better sense of that.
Hi, I'm Jessica Diaz. I live in Charleston. I'm a mom of 2, and I'm a stroke survivor. When I first had my stroke, and my neurologist told me I was really lucky. I thought she was out of her mind. But having spent the last 3 years learning and recovering from stroke, I'm very lucky. Mainly because I'm doing great today. I don't have any real issue, health issues, that is. And the reason is because I was treated and diagnosed. I didn't have typical stroke symptoms, and what I mean by typical are the ones that I had imagined. I had my stroke at 36. I didn't even know I was eligible for one. I thought it was almost something that happened to old and unhealthy people. I took my time getting into the hospital, and I had some unusual symptoms of numbness and a really bad headache. Very lucky I went to Mass General, where they were very thorough in evaluating me. I had 2 different neurologists trying to decide if my symptoms were enough to take further diagnosis. So they gave me an MRI and it was showing that I had a mild stroke. At that point, I couldn't move my left leg and was told I'd be there for 5 weeks. I did wake up the next morning and had function of my leg. But what's really important is, one, that I got the diagnosis and the treatment that followed. Because with a mild stroke, a massive stroke, I've been a day away, a month away, a year away, I wouldn't have known. So the fact that it was discovered, I was in the hospital that was quick to treat it, is a big part of why I'm doing so well today. Having been involved with the Stroke Association for 3 years, I've had the pleasure of meeting so many stroke survivors, and many of them, unfortunately, are not as lucky as I am. They were misdiagnosed. They went to a hospital that may not have been equipped to give them the TPA, and that made all the difference between them recovering immediately within 3 hours of getting back, and instead of living a life with disability. So I'm a huge supporter, hopefully making sure that I get the right treatment into the right hospital, and also awareness about all the symptoms, prevention of stroke.
Hi, my name is Christina Hill. I am 20 years old. I'm from Milton, but I'm a freshman in college. So just a little about me. When I was 14, I suffered from a stroke, and I had the classic symptoms, and I kept asking what is wrong with me, and no one could really tell me what was going on. They couldn't give me a reason why I couldn't walk, I couldn't talk, and I got to my local hospital, and they thought I was on drugs if I was drunk, and they took my blood, and they realized that something was actually wrong with me. My white count was through the roof. But before we did that, they mom sent me home with an ear infection. So before they actually took my blood, they found out that my body was fighting off something. So they took me via ambulance into town to one of the Boston hospitals, and I kept asking, like, what is going on with me? And all these doctors were saying on my bed could not give me a straight answer. After going through a bunch of tests, they thought that I had food poisoning and they wanted to send me home. So because of my age, I wasn't given a proper system of care, and that really resulted in how my side effects, like till this day. They told me I was probably never going to walk again, and at the time, being 14 years old, I was on a national hockey team, a club soccer team, and my real concern was if I was going to go to a hockey tournament that next weekend. So I really did put in a lot of work into my rehab, and I played hockey all throughout high school, and played soccer, and I play soccer now in college, so I've come a long way, but still, when I think back to what happened to me, I probably would have had a shorter recovery or something along those lines if they diagnosed me a lot sooner. So even though it was a negative situation, it's turned into something positive because I'm here in front of all of you today. I speak for schools for the American Heart Association. I'm on Teddy's team with Teddy Bruschi, so I made it my real mission to come out and discuss what happened to me, but to educate a lot of people. So this is why, I'm here to share my passion with all of you, so thank you.
My name is Vanessa Gormley. I'm a clinical nurse specialist in neuroscience at Massachusetts General Hospital and a staunch supporter of the American Heart and Stroke Association, and in particular this bill. These two wonderful survivors in front of us are the new faces of stroke, we hope. We, as you are already hopefully know, it's number 5 killer, leading cause of long-term disability in the United States. And time is brain, so the faster we can treat patients interdisciplinary-wise, right? It's not just a stroke neurologist, it's a team of nurses, radiologists, technicians, ED physicians who help, and EMS crew who move the patient through as fast as we can to get the treatment that they need. More and more research is showing that as soon as you get to the hospital, if we can get you to that CT, get a brain image, and identify whether or not you're suffering from an ischemic stroke, we can truly save the patient from a disabling outcome. Other cities, I was actually just telling Allison, that have mobile stroke units where CT scanners are in ambulances. This is in Houston, Texas, and at the Cleveland Clinic, where an ambulance has a CT scanner, a nurse is giving TPA, and when the patient arrives in the emergency department, we're actually trying to figure out what the cause of the stroke was, instead of treating the stroke when they're in the hospital. So really, truly, time is brain. We want to make sure that there's more successful outcomes, and our interdisciplinary teams are very much honed in on and trained to identify the signs and symptoms of stroke and treat accordingly. And then, of course, in terms of tertiary prevention, really make sure that patients have better outcomes. And we all know that they're at a higher risk of stroke after their first one. So making sure they're on the right treatment regimen, educating the community, and continuing their rehabilitation is really, really important. A stroke system of care does that. It's really, truly comprehensive. So I thank you for your time, and this is a really important cause, so appreciate it.
Thank you very much for your testimony. We appreciate it. Yeah, two stroke survivors, and we're so pleased that you're doing well. Good luck with your exams. You still have good time to come and testify. Thank you. Okay. Was there anyone else who was here to testify on these two bills, House 1919 and Senate 1189? Then we are going to move to House Bill 1931, filed by Rep. Dwyer, and we have Tom Sullivan.
Good afternoon, thank you for having me. My name is Tom Sullivan. I'm the Vice President of Finance and Chief Financial Officer of Harrington Healthcare System in Southbridge, Massachusetts. Harrington Healthcare is a comprehensive regional healthcare system anchored by a modern 114-bed acute care hospital serving South Worcester County. In addition to the main hospital campus, we have a freestanding cancer center on our Southbridge campus, a comprehensive outpatient facility in Webster, the old Hubbard Hospital, a large medical office building in Charlton, and satellite physician and outpatient mental health facilities throughout the region. Despite our growth, our mission has been consistent: to provide our patients with high-quality, needed medical services and a safe environment while maintaining our independence. This has become increasingly difficult in the financial climate of unlimited need and finite resources. Given the significant and increasing urgent need to address mental health and substance abuse issues related to healthcare issues, particularly in rural and difficult to access parts of our state, it is increasingly clear that the Commonwealth must revisit the definition that nearly 4 years ago reflected a very different healthcare environment. As a result, it is clear that in order to address the glaring gaps in this area, geographical isolated hospitals with inpatient psych units must qualify for disproportionate share hospital, and further, must be placed in the best tier in any and all commercial contracts. House 1931, filed by Representative James Dwyer, would accomplish these goals. Chapter 224 identified a group of hospitals that were located 20 miles from other hospitals in Massachusetts. If you look at this group of hospitals, they fall into two sections in the state: Cape and Islands and west of Worcester are Route 290. The hospitals are generally located in industrial cities, older industrial cities, or towns where unemployment is higher than the state average, income levels are below state averages, and road access is more difficult and there is limited public transportation. The health statuses of these communities tend to be below the state average, and the need for mental health is greater. The rationale for this is in tiering. Because of the transportation issues, road configuration, and distances, people who live in the service area of higher tiered hospitals are still going to that hospital and having higher out-of-pocket expenses. Higher out-of-pocket expenses create three different scenarios. First of all, it creates a greater financial hardships on individuals who are already below the average income. Patients do not pay for out-of-pocket expenses, and this can create more bad debts for the hospital. And more importantly, patients aren't seeking the health care needs that they need because the tiering is a barrier. As I always say, tiering is limiting the access for patients. In regards to the relative price limits, although geographically isolated hospitals can demand higher prices because of local and limited competition, they should not be rewarded for this competitive edge. The limits provide incentives for isolated hospitals to reduce rates. Overall, since relative rates are benchmarks for all hospitals, as you know, the HPC and the Attorney General's office do a relative price comparison. Isolated hospitals need to move with the overall market and not by having a competitive advantage. By changing tiering, this has no impact on the state budget. Disproportionate share classifications. Individuals who need mental health services are a vulnerable population. Access to services and also transportation continues to be a problem for this group. Allowing isolated hospitals to qualify for state DISH if they provide inpatient and outpatient mental health services does the following. It provides incentives for the hospital to keep operating mental health programs in the isolated communities. The additional DISH dollars help subsidize mental health programs without increasing funding in the mental health budget. There is no financial impact of this proposal on the state budget either. It's just a redistribution of funds. Since we started this campaign on talking about isolated hospitals and disproportionate share hospitals, We've also had other conversations within the Commonwealth here, but I have not submitted a proposal on this. But in addition to the legislation that we're proposing here, I'd like to add this comment to other things. As we know, we have been battling substance abuse in outpatient mental health services. I'd like to add to this, if you have psych emergency services, outpatient mental health services, and substance abuse programs, these programs should also be reimbursed through the free care pool if they are, if the person's eligible and they create a bad debt. Right now, it's only emergency room bad debts, and if you qualify for free care. I'm suggesting that if we look at mental health as a whole, that some of those dollars also be eligible for the free care eligibility.
So Sullivan, thank you. Time is up. Would you be able to wrap up?
I'm done.
Okay, great, perfect.
I'm done.
All right, we got it. And please make sure we have it in writing.
Yes, you do have it. I think, except for that last little minute.
Okay, that would be helpful as well. Thank you.
Okay.
Any questions? Okay, thank you very much.
Thank you.
Was there anyone else here to testify on the same bill, House 1931? Okay. Anyone here for House 1969 by Representative Golden? Okay. House 1986 by Representative Topka. House 1987, also Representative Topka. House 1990, Representative Topka. House 2018, Representative Mark. House 2024, by Representative Mandel. Okay. All right, we're going to move then to House 2029, Representative O'Day filed this bill, and we have Mary Ann Sullivan and Reva Newfield signed up to testify. Actually, they testified before, didn't they? Yes. Along with Representative O'Day. So they're going to testify.
Okay, I signed up for that too.
Oh, did you? Okay. You're not Chris Johnson, are you? Look at that. You are next up. All right, Ms. Johnson.
I've never come to one of these before, so I didn't know all the formalities.
You're a quick study.
Yeah, really. Okay, maybe I can make this a little bit more understandable. I'm just an independent researcher in all dimensions of elder affairs. Now, a few years ago, this didn't exist, okay, the observation, inpatient, etc. Somehow, it just started to appear. Now, randomly I heard someone say at a lecture that it was part of the Affordable Care Act, but I talked to some guy who was like, wanted to have a drama. He said there's no truth to that. It is kind of a situation where the old are frail, they're tired, and I do think it's an attempt to take advantage of them. It is not just shifting costs to them, which I'll get to a little later. On many issues, they're being required to, in fact, prepay. Okay, so let's try to make this make sense. You show up in the emergency room with massive chest pains, right? You're an elderly person, you're in the ER. Now, whether the bill that is before you is going to help, they're going to explain to you as you're in massive chest pain, you may not have your bills covered by Medicare. No, there's issues with the wording of the bill. But they can't send you home and say, give us a call tomorrow if you're alive, right? So they will admit you. Now, there's an issue with the verbalization. You are admitted under either circumstance, whether you are a true traditional inpatient or under observation status. So they have to clean that verbalization up. The bill does address that. It says you would be admitted either way. The problem with the bill, which I talked to Mr. Joyce about, is that they're already getting around it. All right? I have an example of an elderly woman in Leominster who's been in and out 3 times since September in the emergency room. And her son, who has tried to help her every 3 times, he was told she is being admitted as an outpatient. And he said, she's going to be admitted as an inpatient as an outpatient? And they said yes. So see how they're already not using the word observation, probably because they're aware of this bill. So I suggested an alternative verbalization to say, you are, if they are going to admit you to the hospital under any circumstances other than traditional inpatient, you are to be given all of this information. Okay, it has to be broader than what it already says. So, how are we doing here? Now, notice that they're not doing this with employer-sponsored health care. Are you going to tell people who come to the hospital and you don't know what's going on? You know, your health care insurance isn't going to pay for this. We're just observing it. Okay, that's really critical. Now, my own husband was in a few months ago because he got a sepsis infection. And since I've been researching this, I saw how they had him for observation. I absolutely panicked. But it doesn't apply to employer-sponsored. It's only the elderly in Medicare they're doing it with. Okay, so they're shifting the cost in prepay. That will come up soon. I talked about changing the language. Okay, now, I randomly went to a Mass Pro conference about a year ago. They've changed their name a couple of times since then. They're like the quality assurance people or something. And a couple of things happened there. They were talking about this. Now, since they've had such a good time getting away with it, as you come in, right? They've got you totally befuddled. What is my status? All right? Well, they're starting to do it on the back end. So let's say somebody comes to the hospital, they're really ill, and they do take you, admit you as a genuine inpatient, right? Traditional inpatient status, employer-sponsored health care. None of this observation. They have the ability to, after you've been there a day or two, change you to observation. They have so much success at the front end, they're doing it at the back end, okay? Now, Mass Pro said that they have to notify you if they do that. Well, if you're that sick, what's the point? You're not hearing it. And the example I'll give you of a lady named Teresa, I told you her son wasn't told of that. She had massive shoulder pain, went through the ER, was in the hospital for 3 days. They told her son she was outpatient, even though she's clearly inpatient, right? They did tell her she was observation. I've talked to them both separately. So here's mixed messages. However, she was in such severe pain, they put her on morphine. Now, how much of that did she do? And how much needed did they? So, the worst I've heard.
You have to start to wrap up.
Oh God, the worst I heard is a guy who was on observation for 12 days. They can't send you home because you're too sick. So they're calling you observation. They then, after 12 days, he was still so sick, they sent him to a nursing home. His bill ended up being $80,000. I heard from the system. They also have up to a year after you leave the hospital to change your status and bill you. And in the particular case of the woman in Leominster, before she could go to rehab, they made her son prepay 2 weeks. Another couple, mid-90s, guy fell, broke his hip, hospital 2 days, didn't need the 3-day. They made her pay cash, $13,000 up front before he could step a toe in for rehab in the nursing home. So they not only shifted costs, they're making it prepay. It's all these chemicals that nobody understands. I could go on forever. I'm a researcher in this area.
Appreciate your testimony, and feel free if you want to give us more folks in writing. That would be helpful.
I got to change. Okay, but it's a very complicated issue. It's very unfair, you know, and it's, I'll be talking with, who is it, O'Day?
Yes.
Okay.
Thank you. Again, appreciate your and your expertise on the issue.
It's painful expertise. It's not good stuff. Thank you.
Okay. Anyone else to testify on this bill, House 2029? Okay. House Bill 2074. Okay. Senate Bill 1134, Senator Crean. Senate Bill 1146, Senator Flanagan. Senate Bill 1148, also Senator Flanagan. Senate Bill 1149, Senator Flanagan. Senate Bill 1159 by Senator Joyce. Actually, that's just a companion bill to House 2029, so we covered that. And then the last bill on the docket today is Senate Bill 1225 by Senator Tarr. Okay, but there's no one else to testify. That concludes this hearing of the Committee on Public Health. I want to thank everyone. I want to wish you all and all the committee members a very happy holiday season. Thank you.